Hello, my name is Sabik and I am a surgical oncologist and population health scientist. And I am the primary investigator on a study called Explanatory Sequential Mixed Methods Investigation of Colorectal Cancer Care Disparities in North Dakota. My collaborator is Dr. Shonda Schroeder. I am the quantitative researcher part of the team, and she is the qualitative researcher part of the team. And our study is aiming to do mixed methods research, which is a combination of quantitative and qualitative research design, where when we do an explanatory sequential model, we start with quantitative data and then we try to use the population at large to help explain the data. So the qualitative research piece is then taking themes from focus groups and interviews that will be conducted of populations and providers. So the context of this is related to colorectal cancer disparities, and North Dakota is notable of being in the highest quintile for colorectal cancer incidence in the United States. And really, over the last few decades, we've seen an improvement in colorectal cancer incidence as well as mortality. However, these improvements have not been seen as uh, as prominently in rural regions. And recent analysis that we conducted using the SEER database has shown that the trends in decreasing incidence rates are different between rural and urban locales, as well as in certain populations, including American Indian, Alaskan Native populations. And so, what we wanted to do is further investigate within our state of North Dakota the examination of the question of travel distance and is how important that is. And travel distance would be considered a spatial barrier to access to care. But in addition, we wanted to look at the role of aspatial barriers. And that may include cultural values and mindset towards obtaining healthcare. It may actually be different between different genders and different races and ethnicities, and that's something to be aware. It may be issues of cost and affordability of care, as well as access to insurance, et cetera. And then it may be quick care coordination in certain regions. And so, in the center part of this poster, you see a diagram that we published in ASCO Daily News a few years ago, which is basically applying a model by Dr. Deer from 1977, but applying it to cancer and kind of looking at 6 dimensions of accessibility. And what we're intending to do in our research is explore all these different domains and their role in impacting the care of our patients in our state. To the left of the screen, you see a graphic of North Dakota, and the counties are all depicted with a choropleth map or heat map. Um, uh, that are highlighting mortality to incidence ratio. And that's calculated by taking mortality rates and incidence rates. And the ratio of these actually may also provide us a surrogate measure of accessibility. And certainly, if a or a person within a region is diagnosed and has still issues in terms of quote obtaining a cure, it may actually have to do with issues of being diagnosed at a later stage or not able to fulfill curative intent treatments. Um, and so what we first did, and this is the on the left side of the screen at the lower part, is use ArcGIS, which is a type of software that allows for spatial analysis, um, to examine data from the North Dakota Cancer Registry. We don't see all the patients or all the patients with colon cancer on this map. We did actually drop for ethics reasons any clusters that are under 5 patients. But these are all clusters of patients within these regions depicted. And this is an image that just is looking at access to HPB subspecialists. We actually have mapped all endoscopists, and endoscopists don't only include GI doctors, they include surgeons, they include family practitioners who practice colonoscopy. But we're able to kind of map that and use actually rural driving distance to get a better understanding of how far people travel if they are co-located in a rural zip code or a urban zip code, which was determined by RUCA code. And we did find significant differences across the board in terms of rural travel for endoscopic services to colorectal surgeons, which in the state of North Dakota would be in Bismarck or Fargo. And that's simply more relevant for rectal cancer care. General surgeons do the majority of colorectal cancer care, particularly early stage care. And what we're kind of looking at is for subspecialists for more complex care. And what this map does kind of state in terms of what the obvious is that rural patients in our state, which is a very highly rural state, are traveling further than our urban patients because of, as expected, the a greater travel distance for these types of services. What we then looked at, and this is in terms of this middle lower pictures. These are Kaplan-Meier curves, and these the one on the left is actually looking at MIR, which is mortality incidence rate, and we would expect that the higher MIR groups would have a higher mortalities. But what we're looking at survival, and survival is a little bit different because it looks at from diagnosis how long a patient is being followed and how and if they die or the time point where they die. And what we do show is that there is a correlation in terms of MIR quintile and survival, and the median survival is 3.9 years for hotspot counties versus 6.7 years for low spot counties. And we certainly didn't see a huge difference in terms of stage of diagnosis between these counties, but there were actually more unstaged cancers in the hotspot regions, and that may be a lack of whether it be oncologists or physicians who are able to interpret data and present a stage for that patient prior to their death. And that is in terms of, in many ways, the fact that people are being unstaged when they have a diagnosis of a cancer in and of itself is a disparity. On the right side is simply an image that shows that the distance from hepatobiliary surgeons was correlated with survival. That the further you were, that there was actually a decrease in survival, and that may also be a surrogate to other factors. They may not have directly benefited from HPB surgeons, but HPB surgeons are available to do management of patients who do have stage 4 disease, including liver metastectomies, which is something that has been shown to be curative in many patients with oligometastatic disease. So on the right side of this graphic, we can see that the top is going over our questionnaires. And we did actually population level data collection where we submitted surveys by random purposeful sampling to North Dakota residents, kind of focusing on the hotspot and low spots so purposeful sampling. But we did receive responses from low spot county, middle quintile counties, and hotspot county residents. And we did not actually find a significant difference in most demographics of the residents. And we did actually ask the respondents as part of the questionnaire, the EuroQual 5-question survey, which looks at perceptions of current health state. And our population respondents did not have any difference in that. We also did a mistrust survey, and there was no difference. And there was not actually a lot of mistrust in healthcare within respondents from our state as a whole. We did find that respondents from hotspot counties compared to low spot counties were more likely to live in a rural zip code. Actually, 100% were versus 56%. They were less likely to be married or have a domestic partner, 66% versus 93%. And that's an important finding that has actually been looked more and more in terms of social support and the role in terms of cancer survival. These patients were, or these populations were less likely to have an annual income over $50,000. And we actually looked at this both ways in terms of our survey as well as what we know from county level correlation. And these hotspot regions are actually technically under the poverty line. But these respondents were also less likely to have a bachelor's or higher level college degree at 17% versus 64%. They had higher estimated travel expenses for specialty care. And that actually could be important in terms of people being able to pay for their gas money and being able to travel if they needed surgery or more complex therapies that might be outside of their region. When we looked at preferred screening modality, the residents in hotspot counties actually overwhelmingly preferred colonoscopy, and low spot counties as well as middle spot counties had a preference to Cologuard. We actually did not find that any respondents actually selected no screen as of interest. And that this all obviously may be an issue of respondent bias, that people who take the time to fill out a survey may be more likely to accept health care. But certainly this was of interest, that our respondents were actually seem to be actually accepting and engaged with screening. Below, we see a graph, and this is a little bit hard to show in a poster, but it is actually looking at travel time to services. And we actually have on the x-axis ranging from travel to prepackaged food and beverages, fresh fruits and vegetables, regular healthcare visits, general dental visits, colonoscopy services, minor surgery, major surgery, and cancer care. We can see that there are differences between low spot counties and hot spot counties. And then within those counties, there are actually differences in travel for some of these services between summer travel and winter travel, which is something that's, I think, unique to North Dakota, but living here, it's not totally surprising. At the same time, I think what we do see as significant findings, in particular, the hotspot counties. The travel time for colonoscopy services was around 60 to 80 minutes, while in the low spot counties, it was around 30 to 40 minutes. So that that's one-way travel. And so that may become important in terms of likelihood of uptake. And certainly we can see that that not a lot of differences between travel to minor surgery and major surgery or getting cancer care, but those are certainly a little bit higher than going to the primary care provider. So overall, in terms of our next steps, we actually do have focus groups that are being scheduled for the end of this month and next month. And so those are underway in our hotspot and low spot counties. And we're studying those in gender-specific community member cohorts. And our intention is to explore community attitudes, behaviors, values, and beliefs towards various aspects of obtaining care. And specific questions will obviously pertain to word screening. Um, we're later going to be examining provider interviews, and our intention is to further our research towards developing an intervention that we can further apply to help reduce disparities in North Dakota. I'm happy to take any questions if you see me or email me. Feel free. Thank you very much for listening. Bye bye.